everyone. In this episode, I interview Professor K Ray Chaudhuri about Parkinson's disease. If you enjoy this podcast, please hit the like and subscribe buttons or visit iforgottooaskthedoctor.com. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor K Ray Chaudhuri about Parkinson's disease. Ray is a consultant neurologist and professor of neurology and movement disorders. He's internationally known for pioneering modern care for patients with Parkinson's disease. His particular research interest is defining non-motor symptoms and non-motor phenotypes of Parkinson's disease. He is the founding chairman of the International Movement Disorder Society Non-Motor Study Group. He is extensively published in the medical literature, and I am honored to have him on the show. Ray, welcome. Thank you so much for joining me today.
Thank you very much for that kind introduction. Thank you. Pleasure to be here.
So, Ray, I'm always interested to know why high flyers such as yourself chose their particular field of medicine in which to practice. So can you enlighten us as to why you chose the area of Parkinson's disease in which to practice?
Yeah, it's a good question. So I think perhaps going back to my childhood and younger days, I come from a very strong family of medicine. My grandfather and my father were both medics and academic clinicians.
Mm-hmm.
So I was quite influenced by their ways of thinking and ways of life. And of course, I've always found looking after people to be a real passion for myself. So medicine comes in there. And then my father was interested in neurology. I saw a lot of patients with neurological problems, including Parkinson's, when I was growing up. And my first neurology job in the UK happened to be in the field of Parkinson's, where I ran a clinical trial and I saw the quite dramatic effect of drugs on people with rather disabling symptoms. So that made me feel that this is the area I wanted to develop and specialize in. And of course, now I realize it's the fastest growing neurodegenerative disorder in the world. 1 in 50 of us who are over the age of 80 will get Parkinson's. So it seems my decision was vindicated.
Absolutely. So, Ray, as you know, this podcast is aimed at educating patients. And as a result, we try to avoid medical terminology as far as possible so that it remains as accessible as possible to everyone. So let's start with the basics. What is exactly Parkinson's disease and why does it happen?
So if we look at it from a broader perspective, Parkinson's disease is not really a single disorder, but it's a problem where people tend to lose the dopamine cells. Dopamine is a hormone that we all have in our brain. It's a bit like if your body is a car, dopamine is the petrol. So we tend to lose that as we get older anyway, for reasons not entirely clear. Some people lose it at a faster rate than the others. And these are the people who end up developing Parkinson's syndrome or Parkinson's disease, which can really affect anybody from the ages of 30 to the age of 90. So no age is bad, but it's commoner in the older age group over the ages of 70. The condition is associated with typical what we call movement problems, and this could be slowness, a shaking or tremor, and also stiffness. The muscles become quite stiff. We call it rigidity. And balance issues. People have difficulty in turning, initiating walk, and so on. But also, as you also mentioned in your introduction, non-movement problems. And the non-movement problems that we see are symptoms such as high anxiety, sometimes depression, reduced sense of smell, sleep problems where you can have violent dreams and you can act out your dreams at night. We know that that's a prodromal feature of Parkinson, and also urinary problems and bowel problems and vision. So there are a whole range of things that can occur. And because there are so many symptoms associated with it, we now think that there are various subtypes of Parkinson. One size doesn't fit all.
Okay.
And therefore, uh, while the common problem is dopamine loss in the brain, but there are many different manifestations of this in clinical practice.
Okay. And I always ask about the risk factors for developing particular conditions because, as we know, some risk factors we may not be able to do anything about, such as genetics, but some risk factors perhaps can be altered by lifestyle modifications. So, can you talk us through what the risk factors are for Parkinson's disease or developing it? And is there anything that patients can do to reduce their risks?
Excellent question. So, our understanding of the causation of Parkinson has increased, although we still don't know exactly what causes Parkinson. So, we now know that the fundamental problem, as I said, was a loss of dopamine cells
Hmm.
in the brain. But there is quite strong, compelling evidence to suggest that the problem might either arise in the gut and an abnormal protein called alpha synuclein. Abnormal alpha synuclein is produced in the gut, which might be through an environmental interaction, which might be through some toxic food products, etc. Is transported by a nerve called the vagus nerve to the brain, and it sets out a cascade of problems within the brain caused by that abnormal alpha synuclein. Another school of thought, which is more widely accepted, is the problem occurs from the brain root. So the brain is the first insult, which could be through our olfaction, through our um, sense of smell, because that's exposed to the exterior, and that sets off some abnormal reaction within the brain. What we now know is that Parkinson is likely to be a final causation of multiple interactions. That could be environment. We now know that if people have been substantially exposed to insecticides, pesticides, these are agents that can block dopamine, or have had a significant head injury. When I say significant head injury, I mean head injury that knocks somebody out for a few days, not just a minor
Right.
knock on the head.
Hmm.
That can predispose one to problems in the future. And then we now, on top of that, a lifestyle, so a very sedentary lifestyle, lack of exercise, can also predispose one. We also know that people who are very highly stressed, high levels of anxiety, or who might have marked depression, can also be a predisposing factor. Along with that, genetic susceptibility also plays a part, but a very small part. It's about
Right.
8 to 10% only in the younger group. So if you develop Parkinson in your 30s, in your 40s, then there may be a genetic predisposition in that group. So it's the interaction of all of these that might be finally leading to a process that causes the dopamine cells to die more rapidly than they should. But we also know that Parkinson is not just dopamine, but also associated with loss of serotonin, acetylcholine, and noradrenaline, three other chemicals as well.
Okay, so you say that it can happen at several ages. What would you say is the average or the usual age of onset of Parkinson's disease?
So we look at the um, how common a condition is by two
Hmm.
terms. We call it prevalence and incidence.
Yeah.
If you look at both factors, the prevalence and incidence rises sharply after the ages of 75. So up to the ages of 75 or 70, we have a fairly stable, slow rising prevalence. After that, it rises sharply. So after the ages of 80, for instance, it's currently estimated 1 in 50 people will have symptoms of Parkinson's.
Okay.
Um, having said that, 10% of all people we see have Parkinson below the age of 40 or 45. So we
Wow.
call that young onset Parkinson.
Yeah.
So you can already see if a condition that can affect somebody in their 30s and 40s and also in the 80s and 90s is likely to have wide variability
Yeah.
in the way it expresses itself.
So you mentioned earlier about the symptoms of Parkinson's disease, for example, tremor, so shaking, and rigidity or difficulty starting off motion. Are those the most common symptoms that first takes patients to their GPs?
Yes, so if you think about, there are two, now we understand that Parkinson's can have symptoms that takes you to the doctor for the diagnosis for the first time.
Yeah,
But when you have the diagnosis, the doctor then might ask you about symptoms, then you realize you've had these for a long time. So the symptoms that take you to the doctor are something that are visual. So I call them the visual part of Parkinson. So this might be suddenly somebody notices, oh, my father's right hand has now got a shaking, or he himself notices it. Or somebody notices that I'm a little bit slower than normal. I was to be a very fit and active person. I'm actually slowed down. Some people say their legs are dragging a little bit. Some people say, along with that, the writing is becoming more difficult. I can't sign a check as well as I used to. And then the doctor will say, has the writing become smaller? And then they will say, yes, micrographia.
okay.
So these are the usual symptoms, and stiffness. It's very common to see many people with Parkinson first go to see a pain doctor or a rheumatologist because they think, oh, my shoulder is very stiff. I've got a lot of pain in my shoulders. And then the doctor would say, you've got frozen shoulder. And they will send you to a rheumatologist. Rheumatologists might give you injections in the shoulder, but nothing much happens. Suddenly, a few years later, that same hand becomes stiff and there's a tremor. That's when the penny drops. So these are the more visual symptoms that takes you to the doctor: the stiffness, the tremor, the slowness, the difficulty with writing, and sometimes, as I said, shoulder issues. But then the doctor will ask, or they might be, have you had a reduced sense of smell? And often people will say, yes, I've lost my sense of smell or reduced sense of smell for 10 years. Some people would some people would have this thing called REM behavior disorder, which is REM, which is during sleep.
Yeah,
They might have violent dreams and they might act out the dream. They might hit their bed partners, fall out of bed. We now know that that is a very sensitive indicator of future development of Parkinson's. But of course, if you didn't know, you would not go to the doctor with those
yeah,
symptoms. So
yeah.
these we call prodromal symptoms of Parkinson now. So even the pain, shoulder pain that I described,
Hmm.
uh, REM behavior disorder or sleep dysfunction, as I described, reduced sense of smell. These are symptoms that might be the first marker of the condition, but the doctor will make the diagnosis much later when the symptoms become visible, and these are the movement problems
Yeah.
that we've described.
Okay, brilliant answer. Thank you. And I always ask how these things are diagnosed. So if I notice, I've listened to this podcast and I say, oh my goodness, yeah, I've got a couple of those symptoms. Um, what can I expect if I do go to my doctor? How is it diagnosed? What investigations are performed? How is the diagnosis made in Parkinson?
So, look, diagnosis of Parkinson is not simple. And it really needs to be made with quite a lot of considerations because as soon as you say somebody has Parkinson, you're basically telling that person that you're going to have to live with this condition for the rest of your life
Yeah.
because it's not a curable condition at this moment in time. Just similar to diabetes,
Yeah.
similar to high blood pressure, we can't cure them. But then you must reassure the patient by saying we can actually treat this condition very effectively because we know it is linked to a loss of a chemical. So chemical replacement is the mainstay of management. So the diagnosis is often made on some clinical criteria that you must have a certain type of tremor, you must have a certain type of stiffness, you must have slowness, and you can judge these by doing some clinical tests. And in the majority of cases, a sufficiently informed doctor or a neurologist would be happy to make a diagnosis based on those clinical criteria alone. If you're fortunate to be in a country where there is a lot of infrastructure and a lot of investigations available, then you can support your diagnosis by doing a very specific scan called a DAT scan. I often see people with Parkinson who have MRI brain scans. MRI brain scans are not really useful in Parkinson because MRI cannot show you a chemical.
Yeah.
Here, what you're looking for is a chemical dysfunction, dopamine dysfunction, that can be picked up by a DAT scan. So, for instance, if I developed stiffness and tremor in my right hand, I went to my doctor, and the doctor said, okay, you've got a rest tremor. The tremor is occurring at rest when the hand is resting, and you've got stiffness, you've got slowness in the right hand. I'm going to arrange a DAT scan for you. Then I have a DAT scan. The DAT scan then is likely to show that the dopamine uptake on the left side of my brain, which controls my right hand, is
Hmm.
likely to be low. So it will support my clinical diagnosis. However, it's not essential, and of course, we must remember that in many, many countries around the world, that scan is not available. So, in most cases, it's a clinical diagnosis, but the importance is not to hasten to a diagnosis. If you suspect, it's always worth, but you're not sure for the doctor, it's always worth saying, well, there is a possibility. Let's see you back in 3 or 6 months and see how things are. Because if it is Parkinson, then the symptoms will still be there
Yeah.
and might have progressed a little bit, and that will confirm your diagnosis.
Okay. So that brings me nicely on to my next question, which is if I do have these symptoms, um, would you recommend that I go to my doctor straight away? So that I get treatment as early as possible. So the question I'm asking is, does earlier intervention affect outcomes? Does the earliest diagnosed and treated mean that, I guess, function, etc., is preserved for longer and the disease course is improved better?
So the answer to first part of your question is if you get these symptoms, if you have stiffness on one side is a very important thing.
Mm,
Parkinson usually starts in one side of
one
the body,
side.
not both sides. So if you're a right-handed person and you're having difficulty using your right hand, you feel that there's stiffness there, there's a soft tremor. Yes, you must go and see your doctor as soon as possible.
Okay.
Think in your mind, what are you waiting for? Why should you delay? If you had
Yeah.
anything else, you would go, wouldn't you? If you had pain, you'll go and see your doctor. So, of course, you should go and see your doctor. But then again, it's worth remembering not all doctors have the ability and the knowledge to make a diagnosis of Parkinson's. So, the doctor often would then refer you through to a neurologist
Yeah.
um, or a geriatrician who has an interest in Parkinson. That's fine. Getting yourself checked out, and you might be told, well, we're not sure. This might be a condition we call essential tremor, which is a completely different condition but can present with a tremor. Or they might be told, well, it may be, but we're not sure. Let's wait. Or they may be told, let's get a DAT scan. Or they may be told, yes, it does look like Parkinson. Now, the second part of your question is there is more proof, more evidence now that earlier intervention does help better. And the important thing is management and treatment of Parkinson is not just all drugs.
Hmm.
We now know lifestyle plays a huge part in the management of Parkinson. We know exercise, 150 minutes of exercise per week can produce dopamine, can sprout new nerve cells. And that's obligatory advice we give to our patients. It doesn't matter what type of exercise you do, it bespoke to your culture, to your health state.
Hmm.
Um, I cannot go on, like for instance, it could be running, it could be jogging, It could be some sort of Pilates type exercise. It could be cycling. It could be swimming, whatever suits you. Dance, very useful, very recently shown to be of benefit.
Right.
But you choose that what suits you the most. But what's important is to clock it and to make sure it's 150 minutes a week. That has compelling evidence now that produces almost as much dopamine as the tablets does, but not just that, it can actually protect the nerve cells from dying quickly. So that's a lifestyle change. So if you knew early, you would probably implement that yourself. And along with that comes some other things like care of the bones. 2 in 5 women, 1 in 6 men with Parkinson's have thin bones or osteoporosis. So you should get your bones checked out. If required, you should be on vitamin D and calcium. These are things you can do well before the treatment starts.
Yeah.
So it is quite useful to get a diagnosis and get this full package, medication and lifestyle together. That's the management, modern management of Parkinson's.
Perfect. And I guess that goes to actually it goes for everyone, that exercise,
Yeah,
vitamin D, keeping healthy, and that is just a recurrent theme with every episode of this podcast I do. That diet, exercise, and keeping healthy will stave off, delay, ameliorate many conditions. And I guess it may delay the onset of Parkinson's, even if you're predisposed. I don't know whether it's
there is
preventative
there
as
is
well.
yeah, there is quite strong arguments to the favor of that, although it's not been totally proven. But
Okay.
makes sense that if you actually led a healthy lifestyle, and this becomes more relevant as we become older.
Yeah.
So, it may not be that relevant when you're in 30s and 40s because you're relatively fit,
Yeah.
most people, and you're able to regenerate quickly. But as you cross 50, 60, 70, the role of exercise becomes crucial, particularly in the 60s, 70s, and 80s. That stage group where it's more important, and that stage group we tend not to do exercise because you,
Yes.
you go on to sedentary. It's
Yes.
completely the reverse. And now we know that benefit exercise has benefits not just for Parkinson's but also dementia.
Mm-hmm.
The two go together as well in some situations. So
Yeah.
exercise, particularly in over 60s, is absolutely of crucial importance.
Brilliant. Thank you. That's really clear and really, really useful information that people can institute in their life. Okay, so can you talk us through the other treatment options? So you mentioned about exercise, vitamin D, other non-medical treatments. Are there any other non-medical, and can you talk us through the medical options for treatment?
So let's just touch on, you very correctly pointed out that it's very important to recognize now that Parkinson's treatment is medical and non-medical, both combined together.
Yeah,
Movement and non-movement problems, both needs to be addressed.
yeah,
Perhaps the most fundamental way we treat Parkinson is replacing the dopamine, or what we call dopamine replacement therapy. There are many different medications available for it, but our gold standard is still levodopa, which is converted to dopamine in the body by a set of enzymes. Levodopa has been used since 1962, and it's still our best drug. So everybody with Parkinson will go on to levodopa.
okay,
It's important to note once you're in levodopa, you will be on levodopa for the rest of your life. So it's important to get into harmony with that drug because that's going to be your constant companion. It's not without its problem, but in the long run, but it never loses its efficacy really. And when you're taking levodopa, then you can make the levodopa more effective by blocking the enzymes that break it down. And
okay,
we have a group of drugs called COMT inhibitors or COMT inhibitors, like entacapone or picapone. These can be used along with the levodopa, or we can use another group of drug called rasagiline or safinamide. They block another enzyme called monoamine oxidase. So you can have levodopa as a cornerstone, add entacapone, add opicapone, add safinamide, add rasagiline as necessary. And another group of drug which do not work through the dopamine production, but they go and hit the dopamine receptors directly, These
Mm-hmm.
drugs are called dopamine agonists, and there are several of them: pramipexole, ropinirole. There's a skin patch called retigotine. They all are dopamine agonists. So these are also used. There comes the specialist intervention because you need to know which drug to go
Which one?
for when.
Yeah.
They have their independent side effects, particularly with the dopamine agonists. Recently, over the last 10 years, I guess, we've been aware of impulse control disorders. So these drugs can cause excessive reward seeking behavior because their dopamine is also important for our mood, for
Yeah.
giving us pleasure.
Yeah.
So when you're on agonists, you might suddenly become, start gambling or become hypersexual or start shopping unnecessarily. Some people can eat excessively at night, all reward seeking behavior. So one has to become, again, the specialist and the patient needs to have a conversation about it. But some
Yeah.
of these are normal behaviors anyway, like we all go reward seeking from time to time. But when does it become a problem? So those are the oral drugs, but as the condition progresses, um, we then move on to non-oral drugs because the stomach, from where the tablets are absorbed, becomes quite difficult to control. So the absorption of the tablets, oral drugs, becomes erratic. In this situation, we use non-oral drugs. I've already mentioned the skin patch,
Yeah.
which is used very widely. But then there are injections like apomorphine, injection or infusion, just like insulin is given for diabetes. Then there is deep brain stimulation, which is a brain surgery where electrodes are put into a certain part of the brain in specialist center, has quite dramatic effects in advanced, very selected group of people, not for everybody.
Yeah.
And then also more recently, we're doing the levodopa, the same drug, levodopa, is put into a pump and is put in through a tube into the lower part of the stomach, through a small incision on the stomach wall, abdominal wall. We
Okay.
call it intrajejunal levodopa infusion. That has quite dramatic effects on people where the oral therapy is not working very well. And then more recently, we're getting skin patches, skin infusion, like diabetes, insulin for diabetes as well. So a range of therapies
Yeah.
are now available. A lot of people come and ask me about stem cell, about some other claims. There are loads and lots of stuff on internet you can read and find, but what we go by is evidence-based, approved therapies, and they are these ones at the moment. And
Okay.
then you mentioned something very important about the non-medical element.
Mm-hmm.
We've already talked about vitamin D, calcium, looking after the bone, but also very important to note that when you're taking levodopa tablets, it's very important to keep the stomach free of other food. Because if your stomach is full of cheese, of cafe latte, or milk products, or proteins, they bind to the tablets and prevent the tablet from being absorbed. So, protein and dairy in particular are not big friends of Parkinson. So one trick is to make sure that you take your tablets in empty stomach
Mm-hmm.
and do not eat any dairy or high protein meals for about half an hour after each tablet. After that you can. That's the time it takes for the tablets to pass from the stomach into the jejunum, which is the lower part, upper part of the intestine. And it's from there it's absorbed. So if you have already a stomach full of food,
Yeah.
the tablet's not going to be absorbed properly. And
Yeah.
often I see people are not given this advice. So I usually tell people to have the tablets in empty stomach, leave half an hour. You can have water and so on, no problem. But dairy in particular, avoid till the evening and keep half an hour free from protein. And one other advice is to have a vitamin C tablet every day because vitamin C helps the absorption of dopamine. It's very
Okay.
simple. You can buy it over the counter. You don't have to have sophisticated prescribing. One vitamin C tablet is often very useful.
Okay. So it's pearls like that that can really, really information, if people don't have it, can make a massive difference to the outcomes and how effective
It
treatment is. So
does.
thank you very
That
much.
takes me to one other point which is often ignored: the importance of drinking water.
Hmm.
I'm drinking water. I've suddenly remembered it. It is crucially important that somebody with Parkinson in particular doesn't get dehydrated. Um, and we advocate at least 1.5 to 2 liters of water a day. Because if you get dehydrated, you become constipated. Constipation is a big side effect in Parkinson anyway. And if you're severely constipated, you will not absorb your tablets. And often the doctor needs to do an abdominal x-ray. Some people need an enema. But one simple thing to remember, particularly in hot countries, is to take your 1.5 to 2 liters of water a day. I know it can be a problem. I know it might make you go to the loo more often, but it's a small price to pay.
Yeah, it's worth it. Okay. And wow, it's interesting to hear the myriad of treatment options available for patients with Parkinson's disease. Can you give us an idea? And I know this is difficult when there's so many treatments available, but can you give us an idea about how successful treatment can be and what factors may influence success rates?
Yeah, so um, generally speaking, if you've got your diagnosis right, Parkinson's responds to dopamine replacement therapy very well.
Okay.
We know for the first 4 or 5 years, there's often, it used to be called the honeymoon period. Um, it's the period where you have very good response to tablet. Some people almost go back to normal. Um, but after 3, 4, 5 years, remember, we are also losing dopamine as we age.
Right.
So age-related loss of dopamine starts creating its problem along. So the response to the tablet becomes more erratic. It is quite normal that when you are diagnosed, you will be given a tablet maybe once a day or twice or 3 times a day. But after 4 or 5 years, you might need to take them more frequently because you start getting what we call wearing off the tablet effects, which was lasting for 4 or 5 hours initially, now lasts for only 2 hours, so 2.5 hours. As a result, you need to either take tablets to prolong the dopamine, the levodopa,
Mm-hmm.
and that can be done by adding drugs such as entacapone or opicapone, or you want to take the tablets more frequently, and that's where it makes sure you're taking it in empty stomach, avoiding dairy, all of this stuff comes in. Um, and it's really, that's the situation where one has to think about what would be the next step. And then there are the second group of drugs like the dopamine agonists, the patch, and then finally the advanced therapies come in, which are the injection treatments and other things that I mentioned.
Okay. Thank you. And you mentioned before that one of the side effects to these treatments are reward seeking behavior. Are there any other risks and side effects that you think there must be many because there are many drugs that you've mentioned, but are there any that you think are also worthy of mention today in particular?
Yes, very much so. So with levodopa, I see often mixed messaging. Some people are very scared of taking levodopa early on because they've been told that the drug effect wears off, which is not true. It never wears off.
Okay.
But as we age, the dopa response becomes more unpredictable, and people might get what we call fluctuations. So the same tablet that was effective for 4 hours is now effective for 2 hours. We
Hmm.
call it wearing off. So that's called motor fluctuation. The second problem that occurs, to counteract this, we will give more tablets, and the higher dose causes dyskinesias, which are abnormal movements. So these are the two spectrums we see. One side we see fluctuations or off periods,
Yeah.
the other side we see dyskinesias. So that's one group of side effects. And the other group side effects that occurs mostly in people who've had the condition for 5, 10, 15 years is that people might get what we call um, neuropsychiatric problems. And these are mainly hallucinations or illusions, seeing things which are not there, seeing people passing by. And that can occur with progression of the condition and needs to be addressed separately and can be caused by dopamine agonists, can be caused by some of the other drugs we use for Parkinson, but needs to be addressed. And then that needs its specific treatment in the
Yeah.
long run. And that is why management of Parkinson is so complicated.
Yeah. Absolutely. Absolutely. Okay. So, thank you for those clear and detailed answers to my questions. As you know, I asked listeners beforehand if there are any questions that they'd like me to ask on their behalf. Are you happy to be asked some questions that have been sent in by my listeners?
Yeah, sure.
Okay. So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way which I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question is, my right hand shakes quite a bit. And this is exactly the example you gave earlier. My right hand shakes quite a bit. I have difficulty writing and holding the computer mouse steady. Can this situation be remedied?
So the answer to that question, as I previously alluded to, would be that you should really see your doctor,
Yeah.
and the possibility of Parkinson needs to be excluded. It is on one side, there's shaking and you're having problem, particularly then if you ask yourself if your writings have got smaller, think about your own sense of smell, if it's reduced. These are further indicator. And if it is the case, then the sooner you go on treatment, the better it is.
Okay, so go along and be investigated. Thank you. Okay, second question. How common is it for meds to have no positive effect on symptoms, especially tremors? And what is the outlook for these patients?
So it's an interesting question. Tremor of Parkinson is a very uh, is a phenomenon we still don't understand properly. So there is an element of tremor, the resting tremor as we call it, that
Mm-hmm.
responds well to levodopa, but usually at quite big doses. So levodopa tablet. However, even if your tremor is very well controlled, if you're stressed, if you're under anxiety, if you feel people are looking at you, the tremor will often break through, irrespective of how well controlled your tremor is. And this is because there's a different circuit within the brain that activates tremor. I often see it in people coming to my clinic. Normally, their tremor is well controlled. However, as soon as they're there, there's myself, my nurse specialist, and others are looking at the patient, the tremor starts.
Yeah.
So it's worth remembering that tremor can be controlled by drugs, levodopa. However, high stress and anxiety will often unmask it, but that doesn't mean your tremor has got worse. Very occasionally, in some people who we call tremor dominant Parkinson's, in their situation, tremor is the main problem, you might have to end up having a specific form of surgery to reduce the tremor or ultrasound. These are now available.
Wow, it's very interesting. Okay. Okay, the next question. Can you ask the doctor what he thinks of Mukuna purines?
So Mukuna is a very, very interesting product. It's a herbal product. Which contains dopa,
Okay.
levodopa in it. So, and it's a lot cheaper. Even levodopa can be unaffordable in many countries because the levodopa that we normally prescribe to patients is dopa. Contained within it are two enzyme blockers. One is called carbidopa, one is called bensarazide. These block an enzyme which breaks down dopa in the blood. And two together combined is the commercial preparation we give. They're usually known as Syndopa or Cinemet or Madopar or Stalevo. Stalevo has entacapone with it as well. Mukuna, on the other hand, is widely available. It's about 10 times cheaper and contains levodopa in it, but it doesn't have the enzyme to stop the breakdown. So the amount of dopamine that you finally get into your brain with Mukuna is a little bit less. Having said that, a recent study showed that Mukuna produces as good an effect as Cinnamate in some cases. So if nothing is available, Mukuna could be a very good source of dopamine, and people are looking into it increasingly in some areas such as sub-Saharan Africa, even in parts of India, and so on, where even Cinnamate or Madapa, which we take for granted in the West, might be too expensive for people
Yeah,
to use.
great, thank you. Really helpful. Okay, can gluten intensify some of the symptoms of Parkinson's?
There's no convincing evidence that gluten can exacerbate, but bowel dysfunction is now intricately associated with the phenomenon of Parkinson's. So, if you have gluten sensitivity, then it's good to avoid
Yeah,
gluten in your diet.
okay. Okay, and the next question, I wonder how to take enough B1 sublingual 100 milligrams per day tablets to equal 2000 milligrams of thiamine HCl or even 4000 milligrams as Dr. Constantini once prescribed. So I guess that
I'm not sure
that
it
kind of
has
says,
much to do with Parkinson, to be honest.
okay, okay, okay. Our next question. So our next question is about vitamin B12. Um, Laughing gas can inactivate vitamin B12 in the body. Nitrous oxide, which is laughing gas, can paralyze people because it destroys nerve cells within the spinal cord by inactivating vitamin B12, which is essential for maintaining the lining of the nerves. Alistair Noyes, a consultant neurologist working in London Hospital in the UK, told Insider. The nerve damage can also cause tingling and numbness of the affected body part, with the severity of symptoms depending on how extensive the damage is, according to Noyes, who is also a professor at the Preventive Neurology Unit at the Wilson Institute of Population Health, Queen Mary University of London. People can also lose their balance because signals that tell the brain where parts are positioned don't get transmitted properly. Can this happen, freezing or loss of movement, to us simply from deficient B12?
So yes, I know Alistair very well. He used to be one of the fellows. Now, what you're talking about here is vitamin B12 deficiency.
Yeah.
Vitamin B12 deficiency causes a different group of disorder known as subacute combined degeneration of the cord. Now, that condition can lead to neuropathy, loss of balance, and many other symptoms. That's not really related to Parkinson's. Where it might have an overlap is people who develop a neuropathy after having many years of infusion therapy with levodopa, where levodopa is given to the gut by a tube in
Mm-hmm.
very selected population, as I mentioned, as one of the advanced therapies, might develop vitamin B12 deficiency in that scenario. And that might be where B12 replacement is indicated by just giving B12 injection, but it's not of any direct relevance to Parkinson.
Okay. And I guess that is also an important take home message that neurological symptoms can overlap between varying conditions. And because you have one symptom doesn't necessarily mean you've got Parkinson's. Again, the importance of getting an accurate diagnosis, going along to your doctor to be investigated and diagnosed appropriately so that the treatment is appropriate because different treatments are indicated with different conditions.
It's absolutely important to realize that, like we often say, all that shakes is not Parkinson.
Yeah.
Similarly, any neurological condition is not Parkinson. Parkinson can cause a lot of symptoms, but they're not linked to specifically a specific vitamin and so on. If that was the case, then would have cured the condition by now.
Very true. Very true. Okay, so moving on to our next question, and you mentioned this in passing earlier. Is the reported stem cell therapy effective? And if so, who amongst Parkinson's sufferers would more likely benefit and when could it be available?
So, stem cell has been looked at for the last 25, 30 years, and I'm afraid at the moment still, it's certainly not anywhere where we can say it's safe, tolerated, and has clear evidence base of benefit like we have for levodopa and the other
Okay.
treatments that I described. More worryingly, stem cell has been developed and is being offered in areas where it's not regulated. And we also know that while stem cells or gene therapy can be delivered effectively, we still have an issue with overproduction. So, in many ways, we cannot, while we can trigger dopamine generation in areas of the brain where it's required, we are sometimes unable to stop the overproduction, which in theory might mean almost a malignant process. So,
Right.
we don't, and that is why it's never not been licensed anywhere.
Yeah.
Not just that, it is solely directed towards dopamine, and we know many symptoms of Parkinson, the depression, the pain, the sleep problems, the reduced sense of smell, the memory issues, are not related to dopamine. Freezing off gait is not related to dopamine, most of it. They're related to chemicals such as noradrenaline, such as acetylcholine, such as serotonin, and just pure replacement of the stem cell does not address that. So there are many questions to be answered. Perhaps more relevant is certain focused therapies based on gene mutations. In Parkinson, we now know two specific genes. One is called glucocerebrosidase, or GBA. The other one is called LOCK2. They are very rare in a very small proportion of patients. But if one carries this mutation, it is likely there might be some drugs in future which might be effective in that particular mutation population. One such drug that's currently being trialed is called Ambroxol, and there are
Mhm.
several other trials that's coming up. So in future, you might argue that there might be therapies specifically directed towards some younger patients with gene mutation, but that's a small proportion of people with Parkinson.
Brilliant. Thank you. Okay. And next question is, my mother has Parkinson's and she gets respiratory off periods where her breathing becomes labored. How common are these symptoms and what is the best treatment you have seen for this? We have been treating it with Movapro when it is really bad, but unfortunately, they are pulling this from Canada.
Okay, so as I previously described, one of the complications of levodopa treatment is fluctuations. When you're on, then your drug stops wearing and it wears off.
Yeah.
So when you wear off, people get different symptoms. Respiratory fluctuation is one of them, and it's not uncommon. Um, so the way to treat it is to make your levodopa more effective so you don't wear off. Now that can be done by adding enzyme inhibitors to levodopa that can prolong the effect of this drug. One group of drugs that work for this well is COMT inhibitors or COMT inhibitors. There are two in the market now. One is called entacapone, which has been used since the late 90s, and more recent new kid in the town is opicapone, which was released about 6, 7 years back. Both those drugs are effective and making levodopa more effective. If that doesn't work, then we will often use an injection treatment called apomorphine. This is given just like insulin on the skin by a small syringe, like people can inject it themselves. That rapidly overcomes the off period, and respiratory dyskineses are associated with off periods. So it requires quite a bit of thinking, quite a bit of specialist input,
Yeah.
but the fundamental issue is you need to do something to make sure your levodopa is lasting longer. Another point here is to make sure you've done those simple do's and don'ts with the tablets. Have it in empty stomach, avoid dairy, avoid protein for half an hour, make sure that your stomach is empty, make sure you take a vitamin C every day. Those things can also help.
Perfect. Great. Thank you. Okay. And our last question from the listeners. How are the Peter Tass vibrating gloves and the Q1 vibrating device restoring the neurons throughout thought sorry, restoring the neurons thought to be dead from Parkinson's?
Yeah, the vibration is a form of repetitive exercise, really. And
Okay.
we do know that exercise has an effect on nerve sprouting. However, how much vibrating gloves can actually restore neurons in humans is not really clear. There's been some animal model evidence that that might be the case. So at this moment is very much, um, work in progress. But as I said, broadly, physical exercise is a good thing in Parkinson, 150 minutes a week.
Okay, perfect. Okay. And finally, I've got one more question, and that's from me. You have, Ray, in your career, managed many, many patients with Parkinson's disease. Given the opportunity, is there anything you'd like to say to patients who think that they may have Parkinson's disease or have been diagnosed with it?
Yes, thank you for that question. I think what my message would be that Parkinson um, can be a problematic diagnosis because it's a condition that will stay whenever the diagnosis is made lifelong. But it's something I always say that's the bad news. But the good news is with a combination of lifestyle issues and prudent medical therapy, there's no reason that people with Parkinson will continue to live long and be productive. I have many, many patients who are 15 years into the condition who are still working. So with modern therapy, with lifestyle changes that are required, and with prudent use of medical therapy that are already available, this condition is compatible even with a normal lifespan now.
Wow.
So it is a diagnosis that you need to come to terms with. It needs a lot of sympathy and empathy from the medical profession, the way the diagnosis is given, and the way your management is then planned. But it has to be remembered that management of Parkinson's requires regular follow up. It's not just a one off diagnosis, then come back in a year. That's not ideal. And secondly, it needs close monitoring and involvement of what we call a multidisciplinary input. So the involvement of a physiotherapist, of a dietitian, of an occupational therapist, of speech and language therapist to make sure your voice is loud, that you're not losing the volume of your voice is equally important.
Okay. So, in closing, Ray, it only remains for me to thank you. Thank you for coming onto the show and sharing your vast knowledge and expertise with us. Thank you so much for supporting my efforts to educate patients. But most of all, thank you so much for your years of distinguished work in this field to the benefit of patients with Parkinson's disease. And can I just say that your expertise and your passion have been absolutely clear throughout this interview. Thank you very much.
You're very welcome. I hope it helps people with Parkinson's and their carers.
Thank you. Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.